Hello everyone and welcome to our module on abnormal uterine bleeding. Abnormal uterine bleeding is a term that historically was very poorly defined, and lots of different definitions were used when taking care of patients. So a number of years ago, a committee called FIGO MDC got together and defined normal menstruation, and once defined, abnormal uterine bleeding meant any variation from this normal pattern of menstruation. So according to the FIGO MDC definition, normal menstruation should occur every 24 to 38 days, and the variation from one cycle to the next should be less than 7 to 9 days. Menstruation should last up to 8 days, and it should involve less than 80 milliliters of blood loss, which is very difficult to assess clinically, but nevertheless this is the definition. So based on this definition, abnormal uterine bleeding is any variation from this normal pattern. Based on the FIGO MDC definitions, there are a number of subtypes of abnormal uterine bleeding. So uterine bleeding can be frequent if it's more often than every 24 days, or infrequent if it's less often than every 28 days. Prolonged menstrual bleeding lasts more than 8 days, and heavy menstrual bleeding is more than 80 cc's per cycle, which, as I said, is very difficult to assess clinically. There are some older terms which are no longer preferred, although you'll still see them frequently used in clinical practice. Some of these are menorrhagia, which refer to heavy or prolonged bleeding. Metorrhagia is bleeding between normal menses, and menomenorrhagia is heavy bleeding between normal menses. And then finally, oligomenorrhea refers to irregular cycles that are more than 35 days apart. The causes of abnormal uterine bleeding are remembered by the mnemonic palm coin, which is shown on this slide. Many of these disorders I talk about in other videos, and I won't go through now. So you can have abnormal uterine bleeding if there are uterine polyps present, if a woman has uterine adenomyosis or leiomyomas, which are fibroids. We'll talk about this later, but endometrial hyperplasia or cancer is always in the differential diagnosis for abnormal uterine bleeding. Women who have any form of coagulopathy can have prolonged and heavy menses. We'll talk in a minute about how ovulatory dysfunction can lead to abnormal uterine bleeding. Endometrial causes is really a diagnosis of exclusion. There are some women who have abnormal uterine bleeding, but they have no other apparent reason for it. These women are often said to have an endometrial cause of abnormal uterine bleeding. There are iatrogenic causes. For example, IUDs can cause uterine bleeding. Certain drugs are associated with uterine bleeding. And then the last category is not otherwise specified. And you should be aware that the palm coin mnemonic is often used to describe the subtype of abnormal uterine bleeding. For example, women will be said to have AUB-O if they have ovulatory dysfunction, or AUB-E if they have endometrial causes. Let's talk in a little bit more detail about AUB-O, which is abnormal uterine bleeding due to ovulatory dysfunction. This occurs in women who have menstrual cycles without ovulation. If there's no ovulation, there will be no formation of the corpus luteum. This will lead to an absence of the luteal phase of the ovary and no switch in the ovary to progesterone secretion. If you look at this image on the screen, after the egg is released, in other words after ovulation, the corpus luteum forms and it produces high levels of progesterone. If there's no ovulation, the corpus luteum doesn't form and progesterone levels don't go up like they should. When this happens, there will be excessive endometrial growth from estrogen. Estrogen levels will still be elevated, but there's no progesterone to oppose the estrogen effects. So this leads to so-called unopposed growth from estrogen and a lack of progesterone. And so clinically, what women will report is irregular bleeding when they are not ovulating. They can have no bleeding for 1 or more months, and then other phases with spotting or heavy bleeding. And so in the differential for this pattern of abnormal uterine bleeding is the possibility that the woman may have ovulatory dysfunction. Ovulatory dysfunction is common in certain clinical scenarios. First of all, it's common at menarche. When puberty begins, there's an underdeveloped hypothalamus pituitary ovarian axis, and so there can be one or many cycles where there's no ovulation, and that can lead to this type of abnormal uterine bleeding. It's also common approaching menopause. Women approaching menopause ovulate less, but they continue to produce estrogen, and this can lead to ovulatory dysfunction, and this can lead to irregular bleeding from that. AUBO is also common in certain disorders. It's a classic feature of polycystic ovarian syndrome, which I talk about in other videos. It's common in women with obesity, also in women with thyroid disease. And so the diagnosis is usually made clinically by excluding other causes of abnormal uterine bleeding and identifying a woman in one of these classic scenarios, and then treatment is aimed at the underlying cause. Shown on this slide are some of the elements of the workup that's done for abnormal uterine bleeding. First of all, history and physical examination are key. In many cases, the diagnosis can be made from this alone. Standard testing usually involves a beta-HCG test to rule out pregnancy and a CBC test to exclude that the woman could be anemic from significant bleeding. Other tests are done in select cases. If you think there may be thyroid disease, a TSH can be done. Hyperprolactinemia will cause anovulation, so you can check a prolactin level if you think a woman might have a prolactinoma or is on a drug that could elevate the prolactin level. FSH, estradiol, and LH can also be measured. FSH goes up in premature ovarian failure, which can cause anovulation. Estradiol also gets low in premature ovarian failure. And then the ratio of FSH to LH can be suggestive of polycystic ovarian syndrome. And then you can also check coagulation tests like the PT and PTT if you think coagulation may be the cause of the woman's bleeding. After the workup on the last slide, the next test that's usually performed is a pelvic ultrasound. This is the first-line imaging choice for abnormal uterine bleeding in most women. It's indicated if there are any abnormalities on bimanual examination of the uterus and ovaries. It's also indicated if symptoms are persisting after initial treatment. It's also indicated if the pelvic exam is limited by body habitus. And the idea here is that the ultrasound can identify a number of the structural causes of uterine bleeding, things like adenomyosis and leiomyomas. Another test done in select cases is a hysteroscopy. This is a procedure that can often be done in the office. It involves inserting a camera into the uterus. It allows direct visualization of the endometrial cavity and the endometrial lining. It can detect polyps. It can also detect small fibroids. And then you can also perform an endometrial biopsy while you are visualizing the endometrial lining with the hysteroscope, and we'll talk about this in the next slide. An alternative to hysteroscopy that's used less frequently is called saline infusion sonography or sonohysterography. This is basically just injecting saline into the uterus while you're doing a transvaginal ultrasound. And so sometimes this will allow you to detect polyps or small fibroids better than you can do with transvaginal ultrasound alone. Basically, the idea is to flood the uterine cavity with saline so you can visualize structural abnormalities. It's a messy procedure, and so it's only done in select cases where you're trying to use ultrasound to fully visualize the uterine cavity. On your boards and in real life, a major clinical decision you must make in any woman with abnormal uterine bleeding is whether or not to perform an endometrial biopsy. This is done to exclude a uterine malignancy, and as I said on the last slide, it can be done with hysteroscopy guidance. Basically, you can use the hysteroscope to see the lining of the endometrium and then take a biopsy sample. So in women who are postmenopausal with uterine bleeding, an endometrial biopsy is almost always done. In women who are premenopausal, an endometrial biopsy is done if they have abnormal uterine bleeding and they have risk factors for endometrial cancer. Some of the important risk factors are shown on this slide. So women with anovulatory cycles have extra exposure of the uterus to estrogen, and this can lead to endometrial hyperplasia and cancer. So women with that form of abnormal uterine bleeding usually get an endometrial biopsy to exclude malignancy. Women who are obese produce extra estrogen from adipose tissue, and this can stimulate endometrial growth, and this raises the risk of endometrial cancer. Also, women who have never been pregnant are at higher risk for endometrial malignancy, and so they often have an endometrial biopsy when they have abnormal bleeding. Women who are older are more likely to develop malignancy compared to younger women. So in some practices, women who are over 35 or 45 who have abnormal bleeding will be referred for a biopsy. Tamoxifen is a drug used in the treatment and prevention of breast cancer, so women on tamoxifen therapy who have abnormal bleeding usually receive a biopsy. And then lastly, you can measure the thickness of the uterine lining by ultrasound. And so if the uterine lining is abnormally thickened, that's often an indication for a biopsy. The treatment for abnormal uterine bleeding depends on the underlying cause, but you should be aware that for many women with abnormal uterine bleeding, the symptoms get better if they begin therapy with combined oral contraceptives. I talk about these in another video. They contain estrogens and progesterones, and they improve many forms of abnormal uterine bleeding. They make menstrual bleeding more regular and lighter. They also reduce dysmenorrhea, and then of course they provide contraception. So for all of these reasons, these drugs are often the first-line therapy in women with various forms of abnormal uterine bleeding. If the specific problem is heavy menstrual bleeding, so not irregular menstrual bleeding, but heavy or prolonged bleeding, then there are some special treatments that are used. First of all, some women with heavy menstrual bleeding can have severe blood loss, and this needs to be addressed. So the definition of severe blood loss in heavy menstrual bleeding is soaking more than one large pad per hour for several hours, or passing multiple large clots that are bigger than the size of an egg. When these factors are present, the woman needs to be assessed for hemodynamic stability, She may need resuscitation with fluids or blood. A CBC is usually checked because she could be anemic, and sometimes these women require surgical intervention, although most cases can be treated medically. Now, most women with heavy menstrual bleeding do not have severe blood loss, and in those cases, if the heavy menstrual bleeding is chronic or recurrent, there are some special treatments, and some of these are listed on this slide. First of all, if you can identify an underlying cause, that should be treated. So things like polyps, adenomyosis, fibroids, these should all be treated to try and help women with heavy menstrual bleeding. Beyond treating the underlying cause, treatment usually involves some form of progesterone. So progesterone stabilizes the endometrium and helps it become less friable, so it will bleed less. So in women with heavy menstrual bleeding, some treatment involving progesterone is often used. One option is to simply administer high-dose progesterone. This is often done with a drug called Megace, which is megestrol acetate. It's a form of progesterone. Another option is the levonorgestrel intrauterine device. This contains a progesterone compound, and so that often improves heavy menstrual bleeding. And then, as I mentioned earlier, combined oral contraceptives improve many forms of abnormal uterine bleeding. These drugs contain progesterone compounds, and so they also help women with heavy menstrual bleeding. Another special treatment option for women with heavy menstrual bleeding is tranexamic acid. This drug is an antifibrinolytic agent, which means it reduces fibrinolysis, and in doing so it leads to more clotting. It works by blocking the conversion of plasminogen to plasmin, and this leads to more clotting and less menstrual bleeding. This drug is often used in women who can't take combined oral contraceptives. Often these are women who are trying to conceive. When they're trying to conceive, if they're unsuccessful and they have a menstrual period that's heavy, they take this drug only during menses and it limits the bleeding. And then after their menstrual period has passed, they can go back to trying to conceive. It's contraindicated in any woman with a history of thromboembolism or a high risk of thromboembolism, and that's because it causes more clotting. And then NSAIDs are also helpful in women who have heavy menstrual periods. NSAIDs cause endometrial vasoconstriction, and this decreases the volume of menstrual blood loss. And then for women with heavy menstrual bleeding that's chronic or recurrent and doesn't respond to medical therapy, or in women who can't take the medical therapy, there are a couple of invasive options for treatment. One is endometrial ablation. This involves turning portions of the endometrial lining into scar tissue so it won't bleed. You also can identify branches of the uterine artery and embolize them to limit bleeding. And then lastly, hysterectomy is always an option for heavy menstrual bleeding. This is generally reserved for refractory cases in women who no longer wish to have children. And that concludes our module on abnormal uterine bleeding.